Hello, hello. We are back for Module 3, Lesson 5, the final lesson in Module 3. Okay, very exciting. We're going to talk about cancer risks in menopause, and we will briefly touch on some hormone related risks, but we'll mostly be just addressing aging, menopause related risks. Um, because it's most of the time cancer is just a risk of aging. And here's our disclaimer and disclosure. Remember, this is not medical advice. This is just educational informational purpose, and you should seek medical advice from your provider, whether it's a physician's assistant, a nurse practitioner, a naturopathic doctor, or a medical doctor, osteopathic doctor, whoever you're seeing, please talk to them, but take all this knowledge you're learning here and help your friends and your sisters and whoever else. Again, I'm not affiliated with any drug company or laboratory or imaging center. So anything I advise is just my advice based on my knowledge, years of experience, and studying the data. Keep in mind, there's a lot of new data emerging. So let's talk a little about breast cancer because that's, I think, the one that so many women are most afraid of. 1 in 8 women in the United States will get breast cancer. So 1 in 8 is about 12.5%, which is actually kind of high. Like if you have 7 friends, one of you is going to have breast cancer. And the hope is that by going to regular mammography from the age of 40, any breast cancer could be diagnosed very early. Now, you may hear about controversies about too many mammograms isn't good, or I'd rather have an ultrasound. Is ultrasound as good? Or there's now this thing called a thermogram, or can I just get an MRI? I mean, I've heard everything. So the standard of care around the world is mammography. And mammography has been very well studied, and it's known, very well studied, to pick up these very early breast cancers. Is it perfect? No, it misses some cancers. Not because of the fault of the radiologist, but because some breast cancers just don't show up well on mammography. But that's a very small percentage. So most breast cancers can be seen on mammography. Is there a fear about the X-ray amount of radiation you're getting from mammography? It's actually very low. So I would not be concerned about it. Now, this is just, I might be diving too deep into this. Is there a concern about overdiagnosis of breast cancer? Some of you might be thinking, what? What do you mean overdiagnosis? There is a thought that maybe some breast cancers that are very early might go away by themselves if they hadn't been detected and treated. And there are some studies that support that notion, but we don't have enough information on it. So for now, the standard of care is to get your mammogram, usually recommended every year to 2 years, depending on your age and risk factors, starting at age 40. And so then the question is, how do hormones affect the risk of breast cancer? And we now have great data that shows that the types of hormone replacement therapy that we usually give today do not increase the risk of breast cancer. And even in the Women's Health Initiative study, that was the study that came out in 2001 that scared people and made people stop their hormones, if you've heard about it. In that study, as they followed people later on and they analyzed all the data, the women who only took estrogen actually had lower rates of breast cancer. Lower rates of breast cancer. And it's only in the group that took estrogen and progesterone, and the type of progesterone they were giving was a very potent progesterone that actually acted a lot like an estrogen as well. Only those patients had a very slight increased risk of breast cancer after being on hormone therapy for more than 4 years. And now we don't prescribe that progesterone. So we mostly prescribe micronized progesterone, which is more targeted to helping with menopausal symptoms or perimenopausal symptoms, and doesn't have that estrogenic effect that medroxyprogesterone did, which is what they were using. So I want to reassure uh, everyone out there that taking hormone therapy does not increase, the way we prescribe today does not increase the risk of breast cancer. What if you have a family history? It still doesn't. I always refer to an older study that looked followed women for about 20 years. So this is an observational study, so not specifically um, treating them, but observing women with a strong family history of breast cancer for about 20 years. And some of these women took birth control pills and some of them didn't. And the women who, only the women who took really high dose of birth control pill, which we don't prescribe anymore, because this study was started in the 60s, only those women had, and again, keep in mind, the entire group has a high risk of breast cancer based on family history. So only the women who took a really high dose birth control pill had a slightly increased risk for breast cancer over the general population. So there's really no data to support if someone has a family history of breast cancer that they can't take hormones. It's just not true. Okay, so reassuring you, there's even some studies out there that look at women with ductal carcinoma in situ, which is what we call stage 0 breast cancer, and saying that maybe they could even eventually take hormones. I give you another sort of scenario. Let's say you have a 30-year-old patient who gets diagnosed with breast cancer. That's shocking. And a 30-year-old is nowhere near menopause, and she is going to be producing her own natural hormones for quite a while. And no one treats that patient by removing her ovaries, right? You would think if it's all estrogen driven, you would take away the hormones from this young woman. But no one suggests that. So these are just, and because it just isn't the treatment. While oncologists do use certain medications that have anti-estrogen, um, effect, those medications aren't acting as an anti-estrogen everywhere. They're intended to just work as an anti-estrogen on the breast in patients who have the pathology specimen from their cancers tested positive for estrogen receptors. So it's really not something to be concerned about as long as you're going and getting your regular mammograms. I'm still a big advocate for self breast exam and for having a clinical breast exam, meaning a breast exam by a provider, PA, nurse practitioner, a doctor, once a year, and self breast exams so that you know what's normal for you. I think that's important because I've had enough patients self diagnose or find a lump that turned out to be something, even though they were up to date on their mammograms. So I definitely would recommend continuing to do those. Endometrial cancer, otherwise known as uterine cancer. Uterine cancer, we have, pretty clear risk factors for uterine cancer. Obesity and diabetes are risk factors. Usually the diabetes goes hand in hand with the obesity. So we're talking more about type 2 diabetes, not type 1. And unopposed estrogen. What that means is if someone was on estrogen alone in menopause with no progesterone and they still have a uterus, then that lining inside the uterus is building up, and they're not shedding that lining. The progesterone in hormone therapy, which we'll talk about in our next module, progesterone is intended to protect that endometrium or lining of the uterus. So if you only take estrogen, we call that unopposed estrogen, and that over thickens the lining, and then the cells could start to mutate and develop into cancer. obesity is a natural form of abundance of estrogen because in the fat cells, other hormones are converted into more estrogen. So if you're obese or morbidly obese, you have a state of extra estrogen over someone who is lean. And so that can increase your risk for uterine cancer. Okay? So any woman, and we talked about in a previous module, any woman with postmenopausal bleeding after menopause needs to be evaluated. And as we talked about before, evaluation with an ultrasound and or endometrial biopsy of the lining of the uterus. Okay? Don't think, oh, this is going to go away. Don't be in denial about it. Go in and see someone. Okay. Cervical cancer. Cervical cancer increases in relation to, usually it's more of something in younger women because of the exposure to the HPV virus. But just because you're now in menopause doesn't mean you don't have that risk. It has nothing related to hormones in any way. Cervical cancer is caused by most, I want to say, 99% of cervical cancers are caused by a virus called the HPV virus, which is sexually transmitted. Men don't, or whoever your partner is, other people usually don't know, whether it's a man or you partner with a woman, they don't know that they're transmitting this virus because it's not something that causes any symptoms necessarily. It may be picked up on a pap smear. So if you have your routine pap smears, even if the actual cells are normal, they can test for the HPV virus and it can be detected that way. And we're talking really about high risk strains of this virus that cause cervical cancer. So HPV and cervical cancer are still a risk, and especially if there's increased sexual activity with new partners in menopause, then it could be a renewed risk for a woman in menopause. So you still have to be worrying about STDs, as we talked about before. So continue to have those screening pap smears, and now we do the HPV test with the pap smear every 3 to 5 years. Some places are able to do just the HPV test, and who knows what the future is going to bring in terms of screening. Maybe someday you'll just be doing a swab at home and mailing it in. Right now, it's recommended to continue to do this type of screening, cervical cancer screening, until you're age 65, unless you've had a certain type of abnormalities in the prior 20 years, then you have to continue to do it until you're 20 years clean. Ovarian cancer is, I think scarier than having, in my personal opinion, than a lot of other cancers, because we don't detect ovarian cancer until the later stages usually. So usually it doesn't get diagnosed till stage 3 or 4. And the symptoms we want to be aware of are bloating and pelvic pain and early satiety. What does that mean? That you're satiated early, meaning you hardly ate anything and you're already full. Okay? So that's what early satiety means. And that by that point, though, if you're having this kind of bloating and feeling full pretty early, that usually means it's already spread to other parts of the abdomen. It's not just in the ovaries at this point. So yeah, the symptoms are subtle. There's really no screening test. They're doing all sorts of studies all the time on screening tests, but there isn't a screening test. Interestingly, the birth control pill that someone would take, during, for birth control or during their fertility years or reproductive years, birth control pills actually prevent ovarian cancer because they suppress the ovulation. They basically are suppressing that cycle that's happening each month, up and down with the ovaries. Birth control pills are suppressing that and actually help lower the chances of ovarian cancer. So often if someone has a strong family history of ovarian cancer, putting them on a birth control pill can reduce their risk by 40 to 80%. Hormone therapy has not been specifically studied in those cases, but you would extrapolate that ovarian cancer risk would be lower in women who take hormone therapy because it's stabilizing hormones, but there's really no solid data for that. Colorectal cancer. So colorectal cancer, or some people just call it colon cancer, right? Risk increases with age. So the recommendation now is to start colon cancer screening at the age of 45. And screening can be either with a colonoscopy, or if you're of, average risk, it could be also with this uh, something called Cologuard. I think there's another brand similar where you do a stool test and you send it in and they check for certain proteins in your stool. And if you test positive, then you need to have a colonoscopy. So it's a way to avoid the colonoscopy. Um, Colonoscopy itself is not a big deal. Most people complain about the clean out process. So you have to clean out your intestines, and so you drink all this stuff, and it makes you go to the bathroom quite a bit. But the actual procedure itself is usually very minor. They give you sedation, and you wake up, and you didn't even know anything happened. The nice thing about colonoscopy is it should be covered by your insurance at 100%. However, just to be aware, if at the time of the colonoscopy they do find a polyp and they have to clip the polyp, or they find something, that part isn't like 100% covered. It's just a little insurance tidbit. That part will apply to your deductible. So just to anticipate that there could always be some sort of cost related to colonoscopy. And it may be less expensive to get the Cologuard if you're at average risk. If you're not at average risk, if you're at higher risk, you need to have the colonoscopy. All right, well, generally women are at lower risk for colon cancer prior to menopause than men are. And so there is this, there was these theories of how does estrogen lower the chance of colon cancer? And then we know that estrogen actually, if you continue and you take estrogen therapy, it reduces your colon cancer risk by 20 to 40%. 20 to 40%. That is pretty amazing. So if someone has a high risk of colon cancer, it probably would, and they're a woman, it would probably be smart to take estrogen therapy. Lung cancer. Lung cancer is actually the second biggest cancer killer for women, and it's not necessarily the biggest risk factor is just smoking, but a lot of women develop lung cancer without having any smoking history. So it's important to be aware of that. If you have new onset lung symptoms, to get seen and get it checked out. There's a lot of new therapies for lung cancer, so it's definitely something they've developed a lot of new treatments for. But lung cancer is not one of those cancers that's necessarily diagnosed early, especially in women who are non-smokers. If someone was a smoker, then they're typically getting screening testing with a low-dose CAT scan for someone who was a heavy smoker. But someone who's a non-smoker is still at risk for cancer. There's a couple of different kinds of lung cancer. So still at risk for lung cancer, and there's no apparent association with estrogen or progesterone. So just to be aware, that's just something that we need to know about as we're aging. Skin cancer. I think this is really important. I advocate this, for women to get their skin checked every single year. If your primary care provider is not doing a skin check every single year, like a full body skin check, I would go to a dermatologist's office. They may have a nurse practitioner or PA there, or the dermatologist. They do their quick skin check. They mark if there's anything concerning. They'll biopsy you. But skin cancer is so much more treatable when it's caught early, and there's really almost no reason not to catch it early because you can go in every year. So I think of it like cervical cancer, you go in and get your PAPs. Skin cancer, go in and get your skin checked. It's I tell my kids this all the time. 90% of skin damage happens before the age of 18. So most of us, we've damaged our skin already. The best we can do now is to wear sunscreen, stay out of the sun, or wear hats, wear protective clothing. Although we want some sun exposure because of vitamin D conversion. So it's very, there's pluses and minuses. So you want a little sun exposure, but just not too much, and make sure you wear your sunscreen. There's no clear association between any of the skin cancers, whether it's basal cell, squamous cell, or melanoma, with hormones. There's some suggestion with melanoma, but there's no clear data on that. Okay, thyroid cancer. Women, particularly younger women, have higher rates of thyroid cancer than men. And there's no clear link to estrogen or progesterone therapy, and the risk is not greater in menopause. But in younger women, so before menopause or before even perimenopause, there is probably some association with natural estrogen, but it's not clear. And certainly when someone's treated for thyroid cancer, they're not given any estrogen blockers as a treatment. But it's just something to be aware of, that women, before menopause have higher risks of thyroid cancer than men do. Okay, well, our takeaways with this lesson is that breast cancer and uterine cancer are linked to hormones, but breast cancer risk is not increased from hormone therapy. So that's important to know. But breast cancer in general has links to hormones. I think I may not have been clear enough that many cancers have those hormone receptors on them. So they might be treated with hormone blockers directly for breast cancer tissue, breast tissue. Cervical and ovarian cancers remain key risks still once you go into menopause. Colorectal, lung, and skin cancers, those risks rise with age. And remember, colorectal cancer risk can be reduced by taking hormone therapy. And really, the bottom line is it's important to be screening and preventing and being aware of symptoms, and not hesitate to bring those symptoms to your provider. Okay, see you soon for our module 4. I'm so excited.